seminars. Today's seminar will be about COVID and children and young people's mental health, and it will be chaired by Patrizia Pezzoli. So I'm going to hand over to Patrizia to talk about the seminar, but really pleased to see you all here. Look forward to a really exciting term of seminars. If people could ensure that they have their microphones turned off when they're not asking a question or speaking, and then we can ensure that there's no interference. If you have questions during the talks, feel free to post them to the chat, or you can put your virtual hand up. We try to monitor that and get people to ask questions after the talks. There will be questions after each talk, and then there will be also a chance for wider questions and discussion at the end.
Thanks, Essie, for the opening, and welcome everyone. I am Patrizia Pezzoli, and I am a lecturer in the Division of Psychology and Language Sciences at UCL, as well as the Children and Young People's Mental Health Projects lead. And I have the great pleasure to chair the seminar today, where we'll be highlighting some of the interesting work that UCL researchers have conducted on the impact of the COVID-19 pandemic on children and young people's mental health. And we have two speakers today. Our first speaker is Dr. Rosie Mansfield, who is a senior research fellow in the Center for Longitudinal Studies at UCL, where she investigates social isolation, loneliness, and well-being in British birth cohorts. And she also conducts research on school-based mental health interventions. Unfortunately, Rosie couldn't be with us today, so we're going to play a recording of her talk. And Professor Pravita Patale, who was the senior author on the study, kindly made herself available to answer your questions about Rosie's talk. So I'm going to introduce Professor Patale as well. She's an associate professor at UCL, based across the Center for Longitudinal Studies.
Full professor, as of
full professor. Yeah. Full professor now. So congratulations. So she's based across the Center for Longitudinal Studies at the Institute of Education and the MRC Unit for Lifelong Health and Aging at the Faculty of Population Health Sciences. And her research focuses on the risk factors and consequences of mental illness and on reducing the stigma around mental illness, as well as on school-based interventions to support young people's mental health. And then the second talk today will be by Dr. Lee Hudson. And Dr. Hudson is a clinical associate professor at the UCL Great Ormond Street Institute of Child Health and a consultant pediatrician at the Great Ormond Street Hospital, as well as a lead for child and family health at UCL Medical School. And Dr. Hudson's research focuses on the interaction between physical and mental health in children and young people. And as he will tell us, he was involved in studying health and well-being of young people in the UK during the pandemic. And just to reiterate what Essie said about today's Catalyst seminar structure, we will first have Dr. Rosie Mansfield's talk. Then we'll take questions on this talk that will be answered by Professor Patale. And then we will move on to the second talk by Dr. Hudson, followed by the Q&A on his talk specifically. So please post your questions in the chat during the talks, and I will read them on your behalf, or use the raise hand function at the end of the talks, so you may ask the questions yourself. I will go ahead and play Rosie's talk, and perhaps, Pravita, if you could give me confirmation once it's started that everything looks and sounds great. Sounds good. It would be great. Thank you.
Hi, my name is Rosie Mansfield. I'm a research fellow in the Centre for Longitudinal Studies, and today I'm going to be asking the question, can we causally attribute changes in adolescent mental health to the COVID-19 pandemic? I will present to you some of the existing methodological limitations for answering this question, present a natural experiment design and some causal analysis techniques, and some findings from a recent paper. So I didn't do this work alone. The project from which the data has come is funded by the Department for Education England. And the project is a collaboration between the Evidence-Based Practice Unit at the Anna Freud National Centre for Children and Families, UCL, the University of Manchester, and University of Dundee. So I'd just like to highlight the colleagues that collaborated on this particular paper. And Pravitha Patale, the senior author, should be with you today to answer any questions that you might have. So in spring last year, I was involved in a rapid evidence review funded by the Department for Education. So this was interested in all impacts, both educational, health, mental health, of the pandemic on primary and lower secondary children during school closures. And I led on the evidence relating to mental health impacts. And at this point, the evidence was kind of emerging and the quality was very mixed, and so were the findings. So we were seeing some findings that even suggested improvements in mental health and well-being. And at this point, we were starting to also see some particular subgroups that were more negatively impacted, such as girls, children from low-income families, and those with special educational needs. And one of the studies that in the early stages was contributing quite a lot of evidence was the coast-based study, and this is led by researchers at the University of Oxford. This study kick-started very early on in the pandemic in March 2020 and followed children and families throughout the first lockdown and the second lockdown. And you can see that the highest level of mental health symptoms were when the restrictions were highest, and the coast-based study also contributed some evidence on which groups were most negatively impacted, such as girls and children from low-income families. Now, although this study has contributed a lot, the authors do state that it's not a representative sample, and they do not have pre-pandemic scores. So in terms of change in mental health symptoms due to the pandemic, from pre-pandemic to during pandemic, the study is not able to answer that question. And at a national level, we do have some data that aims to answer that question. So the NHS Digital Prevalence Study is a follow-up from the 2017 prevalence study. And they did find a higher proportion of children were experiencing mental health difficulties during COVID. They did, however, suffer quite a low response rate during COVID. And that means that the group that they were comparing may have had potential biases. And due to the pandemic, there were differences in the mode and method of assessment of mental health difficulties before and during the pandemic. And although longitudinal data, this study has longitudinal data, so it has pre-pandemic scores, it is still difficult to separate out developmental changes from pandemic-related impact. And I'll say a bit more about that in a moment. So these were some of the common methodological limitations that we were seeing early on. So as I said, a lack of pre-pandemic comparisons of symptoms. Partly this is due to the fact that many of the longitudinal birth cohorts that we have in Britain were actually older than school age. So they were beyond the kind of school age adolescent years. So they weren't being captured during COVID in these large national cohort studies. So much of the research was based on convenience samples that were cross-sectional, and they were not population-based. In the adolescent population, we also have to consider who the reporter is. And there were differences in studies making it difficult to make comparisons, and many used parent guardian reported mental health, particularly for externalizing difficulties. And you can imagine that during a lockdown, if you've got schools closed and parents trying to work from home, the parent report might be quite different. And one of the big limitations because everybody experienced COVID, is that we don't have studies that have comparable control conditions often. And what is unique about the adolescent population is that we know that there are developmental patterns in mental health difficulties. So we know that year on year throughout adolescence, internalizing difficulties are likely to increase. And we have also in this population seen secular trends with increased mental health difficulties over recent years too. So studies need to account for these things. So the Education for Wellbeing programme provided a unique opportunity to explore the impact of the pandemic on adolescent mental health. The Education for Wellbeing programme is funded by the Department for Education, and it involves some of the largest trials of school-based mental health interventions that have ever happened. So these are the two study protocols for the INSPIRE trial and the AWARE trial. And across the two trials, there are almost 400 primary and secondary schools involved, meaning that there's tens of thousands of pupils involved in the project. So beyond looking at the mental health impacts of these interventions for young people, the project also looks at the implementation of these interventions, as well as the cost effectiveness. But for the purposes of answering the question about pandemic impact, we were interested in the longitudinal mental health data collected as part of the project. And due to the recruitment of schools, because this is such a large undertaking, such big trials, schools were recruited in 2 phases, which actually led to a natural experiment for the impact of COVID. So one group, which we see as the control group, completed baseline mental health measures in September to October 2018. Their 1-year follow-up was taken at January to March 2020. So they did not experience the pandemic between their baseline and their follow-up assessments. Whereas a second group of schools were recruited and took their baseline assessments between September, October 2019, and then their 1-year follow-up was between February and April 2021. So they experienced almost a full year of the pandemic between their baseline and their follow-up. Now, what this design offers is both groups. We account for this potential year-on-year increase in mental health difficulties during adolescence because we have baseline and 1-year follow-up. So that 1-year change is accounted for in both groups. By looking at the baseline differences between groups, we can also see the year change that might account for these kind of yearly increases in adolescent mental health difficulties that we're seeing over the last few decades. So the timing of the pandemic within an ongoing study created a natural experiment, and we were able to tease out these age and time trends to better isolate the impact of the pandemic. What this does rely on is the comparability or the exchangeability between the control group and the COVID-19 group. So these groups needed to be similar on a range of factors known to predict mental health. So I'll say a little bit more about how we tested this in this study. So in terms of participants, we had a total of 11,450 pupils from 178 secondary schools. They were ages 11 to 14 and were from years 7 to 9. In terms of the two groups, we had 6,419 from 90 schools in phase 1, the control group, and 5,031 pupils from 88 schools in the COVID group. Now, in terms of their socio-demographic characteristics, there was an equal split of males and females, and compared to the population of state secondary school pupils in England, you can see how the sample compares. So we had a slightly higher proportion of pupils eligible for free school meals, about the same with special educational needs, and slightly fewer ethnic minority pupils than the population. In terms of the mental health assessments, the short mood and feelings questionnaire was used to assess depressive symptoms. In this study, we used both a continuous outcome and also the proposed threshold for high depressive symptoms of above a score of above 12. And for externalizing difficulties, we used the Me and My Feelings questionnaire. And again, we used the threshold to create a binary outcome for high externalizing difficulties. And then we used the continuous outcome from the Huebner life satisfaction scale. So the main exposure variable was phase, so which phase the school was in, and whether or not, therefore, they were exposed to the pandemic. We also had a number of covariates at the school level, including whether they were urban or rural, the school level deprivation, and also their kind of baseline mental health provision based on what kind of interventions they were already delivering before taking part in the trials. And at the individual level, we had gender, age, ethnicity, free school meal eligibility, special educational needs, and their baseline mental health as covariates. And we used these variables as modifiers to look for possible subgroup differences in the impact of the pandemic too. So in terms of analysis, as I said, the ability for this study to causally attribute the impact changes in mental health to the pandemic relied on the fact that the two groups, the control and COVID groups, were exchangeable or comparable. So we used propensity scores to assess this, and this assessed the kind of propensity to be in the COVID group. And we used individual level and school level characteristics to test the comparability, and we found there to be very little bias, which was really lucky because it means that we could say that these groups were comparable on a range of factors known to predict mental health. For the main analysis, in terms of assessing the impact of the pandemic, we used random intercept for schools, linear for continuous, and logistic for binary outcomes, multivariable regression models. We had mental health outcomes at 1 year follow-up as the dependent variable, and we included a range of school and pupil level covariates that I just showed you. And to look for subgroup differences, we conducted this main analysis with an interaction term between each modifier of interest. And based on the fact that we believed this was a causal assessment, we also produced what's called a population attributable fraction. So what this does is it looks at a scenario in which COVID did not happen, and it assesses the number of cases fewer of high depressive symptoms that you would see had the pandemic not occurred. And you could flip that on its head and say what percentage of cases, what percentage of cases more did we see because the pandemic happened. And this helps to, at the population level, understand the kind of magnitude of impact. We also conducted sensitivity analyses to deal with dropout. There was slightly higher dropout in the COVID group. So we assessed the predictors of dropout across the two groups, and these were consistent. And then we used non-response weights in a sensitivity analysis. And the conclusions were much the same. So we also used multiple imputation for incomplete data at baseline. And again, conclusions were pretty much the same. So here are the overall results for the impact of the pandemic on adolescent mental health. So here we have the model predicted means, controlling for baseline scores and other covariates. And we also have the model predicted probabilities here for the binary outcomes, which have been converted to prevalence rates by multiplying the probabilities by 100. And you can see here that the pandemic increased depressive symptoms and reduced life satisfaction, but that it did not have any significant impact on externalizing difficulties. The effect size for depressive symptoms and life satisfaction was similar. These are standardized in these figures here, and their effect sizes were around 0.14. So here are the results from the population attributable fraction. So we found that these results equate to a 6% increase in high depressive symptoms in the adolescent population, and this is approximately 60,000 more secondary school pupils in England. So this is slightly less than some other less causal studies have found, but it's not an insignificant increase. It shows that there were many pupils during the pandemic experiencing high depressive symptoms that would indicate a need for support. And this was at a time when schools and services were adjusting to and coping with the pandemic too. So there were a lot of pupils in need at this time, and are very likely to continue to be in need of support. In terms of subgroup differences, we found an indication that females were more negatively impacted across all of the different mental health outcomes. We also found that across both the control and the COVID groups, that those eligible for free school meals had lower life satisfaction. But actually in the group that were not eligible for free school meals, they saw a bigger difference between the control and the COVID-19 groups, showing that COVID might have brought that group closer to those eligible for free school meals. So these are some strengths and limitations of the study. So it has a natural experiment design, which means that we can, as close as possible, be confident that we are causally attributing the impact of the pandemic. And this is because we found balanced groups between the control schools and the COVID group. We had a large sample of pupils attending schools across England. So the spread across England meant that this was a nationally representative sample and a large sample. As I said, we did have greater dropout during COVID-19, but when we ran sensitivity analysis, the non-response weights didn't change the conclusions. We can't be sure that the effectiveness of the original interventions may have been compromised during the pandemic in the COVID group. We also ran measurement invariants to look at the extent to which the pandemic itself changed the way that people kind of perceived and answered the different outcome measures. And we found no problems in relation to the primary outcome, but there were some violations of measurement invariants for the secondary outcomes. So there could be more investigation into that, into how the pandemic actually changed the way people answered questions. So to find the full paper, you can go to the Royal Society for Open Science, and the results are also published in a lay report by the Department for Education. And we publish this as a registered report in line with open science practices. So the stage 1 report is published on the Open Science Framework along with the code, and the data will eventually be made available in the same space. Thank you for listening. And if you have any questions, then Pravitha Patale should be there to answer those for you. Thanks very much.
And we thank Rosie for this brilliant talk. I will pass it on. I can't see any questions in the chat at the moment, but I'm going to give it a few seconds, and then we can go with raise hands. Starting with Essie. Essie has a question. Over to you.
That was really, really interesting talk. I'm wondering, Pravitha, I mean, what are the plans to follow up some of these children, and do you know, or what would you predict in terms of how long lasting, you know, the impacts are, and do we have any comparable data as to how they may compare for other pandemics, or have there just simply not been any? I mean, obviously, the degree of lockdown and things like that isn't really anything that we've had in the recent memory. So perhaps there isn't really anything we can compare to, but I'm just wondering maybe how this might compare to something like being impacted by something else that really disrupts your life. I mean, how unique is this to COVID, or just more generically, these other circumstances?
I don't know the answer to any of those questions, Essie. So I suspect as time passes and better data become available, people will look at things like trying to disentangle, because that's the other thing, right? We just looked at COVID pandemic as a whole thing, whereas there are people trying to disentangle lockdowns specifically or school closures specifically. And I think more of that will happen. And I don't think COVID as a thing is so many things. It's infection, it's uncertainty, it's lockdowns, it's closure. So I think what those elements contribute is the more interesting thing, because when we have another pandemic, which we will one day, if we can disentangle which bits were worse and which bits were better, we might have more informed or more sensitive public health approaches that try to balance the cost and benefits of different things more well. Because right now it was all sort of, we guessed. Because there was lots of prediction that the mental health impact on young people of the pandemic would be enormous, and they talked about tsunamis and all of these things, and actually well done research doesn't indicate there was tsunamis.
I think that's a really important message as well, because ultimately human beings are quite resilient, and given that things happen and life isn't always easy, it would be reasonable to expect that there isn't always a completely devastating impact and people bounce back. And of course, here we had something where everyone was in it together as well. So there were also lots of sort of community spirit that was generated during the pandemic, which I think is a sort of an interesting inquiry in and of itself. But I think there is a sort of probably something you're, I'm sure, looking into as well is, of course, the differential impact depending on your life circumstances as well, whether you're a minoritized group, for example, or not. And I think there's some interesting work you must know of, Anne Phoenix and others at IOE that have looked at that, but perhaps not so specifically for children in their case.
Yeah, thank you. Unless there's any other comments on this, I'm gonna.
I think there's a hand up, Patricia.
Andrew. Yes, exactly. To Andrew McWilliams. And then we have a comment in a question in the chat as well.
Yeah, thanks very much. They're massively interesting, and I'm really keen to hear more about the different hypotheses for why there might be an effect. But I was just going to ask about the sort of externalizing symptoms and thinking about the children we see with ADHD. And I was just thinking about self-report measures, or even parent report measures. There's obviously a high heritability of ADHD. So maybe a parent filling in a form has possibly got ADHD as well, and just what your thoughts are really on collecting these large data sets using these kind of self-report measures, and whether or not you're actually picking everyone up.
Yeah, but whatever measures you use, you will not pick up some people well, right? And that's just the way it is. And this is not, we didn't look at ADHD symptoms, we looked at sort of conduct problem symptoms, if that makes sense. We'll still have some problems like you're describing with ADHD. I think the problem with all mental health stuff is, and not just ADHD, like whatever phenotype you're interested in, depression, anxiety, they all have measurement problems. First of all, they're badly defined phenotypes to begin with, and then we measure them badly. So unless somebody has a perfect way of measuring any of them, which I haven't seen yet, and I'm really interested in measurement, I think we always just have to, in this particular case, at least it was the same problems across both groups. So with regards to the question of, can we assess the impacts of the pandemic on mental health? At least how things were measured in these two groups was exactly the same, as in same measures, but also online and things. Because if you compare it to the mental health prevalence study the NHS Digital did, the first sweep 5 years ago, or whatever, was in-person proper clinical interviews, and the pandemic sweep was online questionnaires. So they're not measuring like by like with like. So at least in this case, in all scenarios, we had exactly the same protocol. So we don't have changes in how things were measured. So they were measured badly at all times.
Thanks, Pravita. We have one question in the chat, which is, will there be a follow-up with regards to mental health on adolescents post-pandemic? And Alberto asked, perhaps there will be a decrease in mental health symptoms.
There might be, and we won't know for another little while, I suppose, until the data comes through. I wouldn't be surprised, as Essie was saying earlier, I think we forget how resilient children, everybody can be. And obviously the other problem now is post-pandemic, we're going into another crisis of like massive fuel and food poverty and inequalities widening. So it might be that we see a bounce back from the pandemic, but it also might be that actually another crisis overshadows. So you sort of have things stay the same or get worse, but that won't be a sort of pandemic driven thing. It might be a everything else driven thing. And I don't know how you would tease those apart, because if you didn't find people bouncing back, would you conclude that people don't bounce back from something like a pandemic? Because I don't think you could conclude that, because then they would have been living in this particular crisis we're now living through. So yeah, I think as more data gets collected post-pandemic, we'll learn more, but I'm not entirely sure what we will see and what that will mean. Sorry,
Thank you.
Sorry not have straightforward answers. Today is not my day for straightforward answers, I can tell.
But we look forward to more work from your group and others to find the answers to these questions as well. And we have one more question from Lorna, and then we can move on to Lee's talk. Lorna.
Thank you very much. It was a very interesting and thought-provoking presentation. I work in schools as well as do a lot of work in education. And I may have come in late, so I do apologise if I've missed it. And I say that, soundboard first. I'm interested in what recommendations going forward, because for many young people, this has gone up, you said 6%, which I think many school leaders can see that already in terms of the gap in attainment and mental health, and also the effect on families and deprivation. So for me, teachers are trying to close the gap already, of course, with this new, as you say, economic emergency coming along. I'm interested in how, in terms of the report, what sort of things could you say were any recommendations going forward for school leaders and for those young people who are still suffering in terms of the after effects of COVID, and this could be long lasting, because it's been said that there's a legacy. Okay, a legacy of de-skilling, a legacy of unemployment, a legacy of not being resilient in life, because that's one of the skills that teachers do try to instill in young people, a resilience of life and that sort of thing. So there's a lot of gaps, yes, that are there. So I know this report only can't save everybody, and I'm not saying that, but what sort of things in terms of recommendations would you say to school leaders or those people working in education to try and stem this?
To be completely honest, I don't have a good answer for that. So part of what we were trying to do is estimate the increased need, I suppose, so that people like government and things had an idea of how much more capacity, healthcare services provision, all of these things would be needed to adequately support young people. The problem is, as somebody mentioned in the chat as well, there hasn't been adequate support in the system, whether you think about schools or healthcare services in terms of mental health support specifically, for a long time. So this has basically added to an already existing problem. And I'm afraid, like, the type of analysis and stuff it's not sort of, there is no solution in there. It's more sort of trying to estimate what the scale of the problem and impact might have been. So I don't think I'm the best person to advise sort of schools or young people on what they could do. And Lee's coming next. If he'll have more useful things to say about young people and what they can do.
Right, I might just chip in because I'm a clinician as well as I'm a paediatrician, so I'm not a psychologist or psychiatrist, but I'm going to talk through more broadly about mental health across the pandemic and where we're at, particularly for service use. And I think there's an obvious answer that needs to be more investment in terms of helping people to catch up. And I will talk a little bit about how far behind globally education has left children in my talk in a mo. But I also think that we need some really good evidence for what works in schools. So, it's almost forgotten that prior to the pandemic, there was an NHS long-term plan, which most of the money and the strategy be placed into schools, which actually schools were uncomfortable about first, understandably, because they get so much dropped on them. But they've had it dropped on them without any choice at the moment because of the pandemic's happened and its impacts on education and mental health and socioeconomic status of the families and the systems that people live within. But what we really need is better evidence of what works to deliver mental health in schools. It was always thought there would be lower level interventions early on to try and capture mental health in schools so that CAMHS wouldn't be needed to be used at that tier 3 level and tier 4 level so acutely. But that's been blown up by the pandemic because we've basically got a load of children now who are needing CAMHS who can't get it. And so the preventative stuff almost feels like it's not even going to touch the sides. But of course, we have to do that moving forward. I would say so. I think really the two things is needs to be extra investment in terms of catch up around schools for particularly identifying those children and those schools and those regions where education catch up is required. That needs to be an absolute priority. Whether it is or not, we'll see. And the second issue is about robust evidence for what actually works for children in a school setting where you can capture them. And of course, we haven't even talked about the large number of children who have mental health problems. They're not even in school that wouldn't have been captured in the talk that you've just given. And we know that there are a lot more children now who are not in school compared to pre-pandemic who are suffering. Well, who knows what's happening to them because we don't even know if they're alive, to be fair. So that's all very worrying. And the last thing I would say before I jump into my talk is about this issue of resilience. And I perhaps touched on that before because I think resilience is used in we have to be optimistic, right? Because if we're not optimistic at this point in time, we might as well all just go home because every time you switch the TV on at the moment, there's something bad and awful happening. And we've just come out of the pandemic, and before that we had political upheaval, and it just seems to have been endless since 2010, doesn't it? So we have to be positive, but I think there's also have to be cautious about what we mean by resilient, because we say, children are resilient and people can be resilient. I don't think necessarily being exposed to something without support is the best way to get resilience. It's like in the workplace, get bullied and you'll become resilient. Actually what people need is structured ways to preempt how they deal with situations to get resilience and be resilient. It's something that you need training with and support with. It's not something that you should just get by being thrown in the deep end of a swimming pool to learn to swim. So I think that's also something that we need to understand a bit better. And there's obviously a lot of work in that, and that's not my field. But when we're cautious about saying, everyone will bounce back, actually, a certain proportion of people won't bounce back, and we can't expect an exposure to something to just mean that you will bounce back.
Thank you.
Thanks so much.
Got my soapbox before I even started.
No, thanks so much for this very interesting first discussion, and thanks again, Pravitha, for being available to answer questions for Rosie. And I suggest we move on to Lee's talk.
Thanks. So I'll just let me just share my okay, just to double check that you can see my slides.
Yes, we do.
Okay, excellent.
Okay.
So when I was thinking about what I was going to talk about, I mean, you've had a really good example, a really good presentation there of explicitly about a study which is trying to answer some specific research questions in a really careful way from a data set. I was asked to talk about UCOPE, which was a study of slightly older children, but what I wanted to do was just sort of give a bit of a tour de force really for this Catalyst seminar about child and adolescent mental health during the pandemic. And I'm a clinician scientist, so I suppose one of my other really big areas of interest is where this interacts with clinical services, which has been another part of the evidence in the jigsaw really of it showing how children and young people have suffered from a mental health perspective because of people coming forward for help. And just to talk a little bit about that and some research that's happening around that. I always start talks on COVID with "I come in peace." Even in the research world, if you go on Twitter, you will see it is a bonfire at the moment of people who seem to be polarizing into opposite views. So I always start my talks with an amnesty on opinion, because I am a big believer that in science we can hold two opposite views on something, and perhaps take a lesson from our pure science colleagues in physics, where, you know, they seem to be able to manage light moving as a particle and as a wave, and they're two completely different concepts, but they still manage to be able to work around problems. So there are some clashes here about what happened during the pandemic. Was it enough? You know, a lot of sometimes recriminations, and naturally someone who looks after children, he's going to come down on issues that have particularly affected children and young people in a collateral way because of the pandemic. But that doesn't mean at all, as I'm talking about this, that I have a strong opinion that we should never have locked down, or that, you know, older people are not as important in society. We need to sort of be able to just delete that and think about how we accept some of the things that happened, and now how we move forward to find mitigations, which is clearly what today is about. But I put that at the start just as a preface. I think most don't need to convince anyone who's in this session about the importance of child and adolescent mental health at all, but I think it is worth reflecting at this point on the importance of child and adolescent mental health for the lifespan, because as you know, the vast majority, almost all of lifetime mental health disorders are established by the time you're 25, and about 70% of them by the time you're 15. So what happens in childhood is relevant to childhood, and as someone who looks after children both in research and looks after children in a clinical setting, that's obviously very important to me. But also it's always important when you work in child health and young people's health that you set out how important this is for the whole lifespan, and productivity and tax revenue, and but the burden of health throughout young people's lives as they become adults. It's a movable feast. And also to juxtapose, I suppose, the massive impact that COVID has had on all age groups, but in different ways, as we're focusing on today, and that all of that was bad. But obviously the focus today, as I said, is going to be on children and young people. I'm going to show this picture. Everyone remember it. I've never heard the word unprecedented used in such an unprecedented manner as unprecedented has been used, because I think someone said at the end of the last talk, is there something else we can compare it to? But actually, I don't think in any of our living memories, unless you remember the Second World War, there's probably nothing that's been as impacting in society as this, and it's completely new, really, particularly for high income countries. And I remember very clearly, because I was lucky, I think, because I worked on the front line during the pandemic, and so I wasn't stuck at home, so I didn't have that experience. So we all had very different experiences, and I remember very clearly on March the 16th, when we went into lockdown, going into work and it being like that, just absolutely nobody around, which was bizarre, and I'll be honest with you, slightly harrowing, but also slightly a bit sort of nervously exciting as well, particularly if you're working in clinical settings. Then the other bit of the story here to think about when we think about research in mental health for children and for adults in the pandemic is just, it's not one single story. We tend to think of the pandemic, but in actual fact, the pandemic was a whole load of things that happened over 2 years, to the point where we still have COVID and people are still getting ill from COVID and dying of COVID. So it's not like it's completely gone away. But in terms of the major upheavals that happened in life, like closing schools, workplaces being closed, people going into lockdown, particularly over periods of festivals like Christmas where people couldn't see each other, and that aspect of things, it was a continuous this and then stop and this and then stop. So that is partially one of the problems with understanding the impact of COVID, because it wasn't just one lockdown. Now, I was going to talk briefly about what we know from early on, and I think actually Rosie has already done that really well, and she's covered some of the studies I was going to talk about. So I'll skip through those with just small comment. But as Rosie said, one of the key things is that it's really great actually that we had this very quick turnaround where people set up research projects and people collaborated very quickly to try and understand what was happening. But that data was very convenient sample led. That data was very quickly put together, and for the most part was either cross-sectional or short-term longitudinal. Now, one of the few studies that actually was operating looking at mental health that is out there in children and young people was this study by Berendisi et al. That was running basically 12 samples from three countries looking at depression and anxiety recurrently, and they just happened to have that study running as we went into lockdown. And so the first sort of longitudinal bit of data that we had was from them, which showed basically that anxiety was fairly stable, but depression went up. And we were also hearing from very early in the pandemic, from around Christmas time in 2020 and just afterwards, that from China, cross-sectional studies were reporting high levels of anxiety. Some of the first publications on the mental health impact on children and young people, as you perhaps might expect. We've already talked about UCOPE, so about CoSpace study from Oxford, so I'm not going to go over that again. But that was one of the first studies longitudinally to follow children and in the UK. And as Rosie said, it picked up that certain groups of children, low-income children, low-income family children, and girls, and particularly younger children that were affected, and perhaps adolescents didn't quite have that impact during the first lockdown. And we could hypothesize about why that might be, but certainly anecdotally, knowing lots of adolescents, sort of early adolescents, you know, people perhaps were off their back a little bit around school. And so the reports from problems at that early adolescence were not quite as profound as they were in earlier age groups. And that's demonstrated in this slide here from SDQ. So I'll just talk briefly about UCOPE. So UCOPE was a study that I was a part of, which was pan-UK. So this wasn't a clinical study, it was a study of young people, and it was recruited pragmatically through social media, through networks, through young people's groups. And it was a convenient sample, and it was done very rapidly. And what we did was a cross-sectional baseline data, but we then collected recurrent data. Now, I have to say, most of the data that we've got to present, or we've talked about, and I'm going to talk about this quite briefly today, and I'll give you the link for if you want to go in there to look at it. But what I think was novel about UCOPE is that we looked at 16 to 24-year-olds, because these are a group that tend to get overlooked in lots of arenas, including healthcare, because they're sort of in the valley between when people look at adults and when people look at children. And the studies that have tended to focus on children and young people in the pandemic have tended to be under 19-year-olds. So this was a specific group to look at. And there was a reason we looked at this group, was one, because as a group we were an adolescent focused bunch of researchers who were interested in this group, but we also detected or were worried that this was a group that potentially could do really badly out of the pandemic, before a priori thinking about that, why that might be, because there were people in employment who tend to be employed in service industries, which we know close very rapidly, and the impact that can have on income. We also know that they're not always protected by minimum wages. That group, we know that there's a high level of mental health in this group existing already. And we also know that this is the group that will either potentially be unemployed or at university and away from home. And if they were at university, then at university they had to shift back. There were massive transitions in people's lives where they had to move back to, and a group that we know is socially outward and well, most of us reflect on our lives. That's a period of time when most of us were out and about socially meeting people, and developmentally how important that was. So they were a group we were particularly interested in. So it was an online web-based 20-minute survey, followed by subsequent surveys every 2 weeks, and we got about 1,500 young people. But as I say, this was a convenient sample. It wasn't a existing population, a fairly selected cohort. And I'll just mention the people that worked on that project. It was a wide group of researchers, including Pravitha Patley, who's been on the talk early this morning, colleagues from UCL, colleagues from the University of Sussex, and colleagues from the Imperial College London. And I'll show you the link of that at the end, but you can go and read all of this, and we use the PHQ-9 and the GAD-7 as particular measures for anxiety and for depression. But I think the key points, really, there were 2 reports that are available on UCL, and actually, if you UCL's website, and if you Google UCOPE UCL, then you will be able to find our reports with detail about how and what we did. But I just wanted to share the key points, really. So this first study was 1,200 because we were still recruiting at this point. And although it was a convenient sample, we actually managed to get participants from all across the UK, including Northern Ireland. And 31%, and we had a similar proportion of participants who, when we asked them, had received free meals to national rates of children and young people claiming free school meals. So it was one way of at least trying to find deprivation relevance as a fit for the background population with our sample. So this was in June, July, so this was not right at the beginning of the pandemic, but this was May, June, July, when we first got, people gave us their baseline data, which is what I'm talking about here, and 2 years ago now. About a third of people in the study reported that their income had decreased, which was what we were particularly worried about. The majority of respondents reported that their normal educational employment activities had changed. That's perhaps not a surprise. A quarter of young people reported changes to their living situation. And this was interesting to me as someone who works in healthcare. Those who were receiving ongoing healthcare, so they were already under a healthcare provider for a condition, whether that was physical health or mental health, 40% reported that had been disrupted, and that was higher, about 60%, in those who were receiving mental health care. So I think I'm always very cautious about making inferences from this sample, but it does speak a little bit to one of the reasons perhaps that we did see problems with mental health emerging in this age group, that if you were already getting mental health support, then that was disrupted, which is obviously really important if you're getting mental health support. So then the other report which you can find as well actually looked at mental health. Now we had a biased sample because we had 61% of participants reported they had a previous mental health problem. So that's not a surprise. We put this out because we were measuring mental health and well-being, and you naturally, if you've got a convenient sample, will attract a group who will have existing mental health problems because they will want to tell you about it and they're interested in the survey. But in a sense, it's helpful in understanding people who had existing mental health problems and what happened to them. So half of participants reported high levels of stress since their lockdown. This was 2 or 3 months in. The vast majority of them expected their lives to change afterwards. And nearly half of respondents without mental health problems reported high levels of depressive symptoms. So in that group that didn't have pre-existing mental health problems, we were seeing a significant number that were increasing their mental health symptoms. The thing to also talk about that is still a work in progress, which is an app. So talk about this very briefly as a separate side project that Russell Viner and myself worked on. We took the group later on, we contacted them again. We had ethics to do that through the university, and we did an ethics amendment, and we designed an app to measure their mental health, but also their physical activity. I can't tell you how challenging this was. I'd never designed an app before in research. It was something that and we paired it with industry to do it. And it just, every single problem you can imagine in the pandemic also reflected onto how we progressed this piece of research. So it was the staff, the teams were unwell with COVID at various points. So there was a delay, and we were obviously quite anxious because time was moving through the pandemic and we were wanting to capture key moments like new lockdowns as we went through. And the various processes you have to get through to get an app out there, including going through the app stores, which have quite robust processes for you to put an app out. And it was sort of plus usual admin nightmare for doing research, because this was all on afterwards. But we did get there, and that data is now being looked at. But we didn't get to release the apps until after Christmas. Now look in 2021, so basically a year into the pandemic. That said, we got permission from participants to take step data that went back 6 months. So we have got some interesting step data across various bits of the lockdown, so we can see how physical activity changed in relation to mental health. But there's more of that to come at some point in the future, and perhaps I could come back and talk about that when we've got it. So to finish, basically, at the start of the pandemic, it would seem from these very biased cross-sectional samples that we all had, that there was almost an age-related impact, and how I model it in my mind, that younger age groups were affected significantly, perhaps not as bigger impact on the younger adolescents at that time during the first lockdown, and then a bigger impact on older adolescents and young adults. Rosie already talked about this, and as I'm talking now, we're sort of moving through time. So we're moving away from the first lockdown and the first wave, or whatever you want to call it. And we did start to see evidence from pre-existing data that the mental health of children and young people were being affected, and this prominently has been reported in NHS digital data. But as Rosie said, that was half of people from 2020, half the sample size it was in 2017, but there seemed to be an increase in background rates of mental health disorders in young children and young people who were already in that study. Now, I'm a clinical academic, so I'm interested in how services are affected. And I think how services have been affected is also part of the story of mental health in children and young people, because I think it's a fair assumption that if you're seeing large numbers of children and young people coming forward in greater numbers than before for help, some of that might be people deciding they want help and have been suffering for a long time, but it's likely that that's new caseload, which I think fits with the prevalence data that we're seeing. Of course, during the first lockdown, and this is data from emergency departments across Europe, so I think it's about 30 A&E departments across Europe, including some from the UK. Overall, as you will know, presentations in paediatrics actually decreased. So the number of children and young people going to A&E during the first lockdown dropped dramatically. And that was a major cause of concern for us as paediatricians, because we were quite worried about what was happening at home, with people sitting at home and not coming forward with illnesses. And there is some evidence that there was delay in presentations for some significant health problems. And perhaps that's why there was a surge in presentations later on down the line, that people were just sitting at home and things were getting worse, and then they presented later on, which is why we had this surge after the first wave. But you can see that this is something that we've seen in paediatrics through that first year in the pandemic, that there was a reduction in overall numbers. And you can see during the first pandemic, that shows you here from January, February, March, that across Europe, the number of children that went to A&E decreased overall, and that included mental health disorder presentations, and A&E as an emergency department are common places to go with an acute crisis with your mental health. But this is just children, by the way. But you can also see that relative to all presentations, though, mental health went up. So actually, I think the perception was by people working on the front line in accident and emergency departments looking after children, is that although the numbers overall went down, including mental health presentations, it was actually that there was a disproportionately larger number as a proportion of children and young people presenting with mental health problems. And I think also those numbers don't speak to severity. So my colleagues tell me that there was a much more severe level of presentations, which I'll come on to. So where UCL sits in North Central London, there was a reconfiguration in service, going back to what we did to children. I mean, you know, it really, when you think back to it, we closed children's wards in North Central London and reconfigure them at Great Ormond Street. So that was understandable because there were a large number of adults, but it does sort of fit with where children fit into the story, because about 4 or 5 children's hospitals in our backyard were just closed overnight so that they could get adults in there. And then the children just had to go to Great Ormond Street from A&Es, and we just try and have to work it out, which I think speaks a little bit to the necessity and the desperation and how quickly everyone was having to act, but also where children fitted into the mindset of how we dealt with health. And we definitely saw an increase in the number of emergency health presentations out of hours through the first lockdown in our region, NCL. And the data really speaks for itself, doesn't it? So the Nuffield Trust have recently released figures. You know, there was an 81% increase in referrals to community CAMHS in 2000 versus 2019 in that first year of the pandemic. A 59% increase in urgent or emergency crisis care referrals for children and young people. So that's their mental health and their social care. And children and young people were waiting for treatment in emergency departments for eating disorders, quadrupled. And this is one bit of the story of mental health for children and young people. And I think it's actually really quite depressing, actually, because I think particularly for eating disorders, and I've been involved with that process, we'd reconfigured services in England, at least, really well, to the point where they were doing quite a good job. It was still postcode lottery, but we were doing quite a good job in seeing children and young people in a timely fashion. And as one of my colleagues said about CAMHS, we were already flooded, but basically a flood that's been hit by a tidal wave, because we were making some progress. And it really does feel for CAMHS, in terms of waiting times and the demand on their services, that we've gone back some years, and all that progress we made in sort of tackling waiting times and risk have been dramatically affected. I did a survey last year of general paediatric wards. So what we've seen is a spillover into general children's wards as well, because presumably rising prevalence in the last year or so, plus increased emergency attendances, and the fact that we know that if someone presents in a mental health crisis, there are very few interventions that can stop people having to be admitted to hospital in the moment. And a very common venue to be admitted as a child or a young person when you're in a crisis and can't go home is a general children's ward. Now, the problem with that is that general children's wards were not really ever set up or designed to look after children with acute mental health crises. And in lots of ways, the environment in terms of risk and ligature points, to the training of the nursing staff and the doctors and the healthcare assistants who work on those wards, and how that complements the other reasons that children are there on the ward, and skill sets around applying the Mental Health Act and restraint. These are all things that people have, have had to really struggle with, I think, in general children's settings, because they've had to take the burden of children who weren't able to go home. And one of the complexities that we're finding, and we certainly found during the pandemic where I work, and what I'm hearing from the network, is because you've got a lot of children and young people presenting afresh with problems who aren't known to services. When they present in crisis, that takes longer to sort out and find a safe plan for them to go home. So they're spending more time on hospital wards. But it's always been a part of the routine care. So in 2019, about 6% of unit general children's wards in the UK, when surveyed, 6% of beds per year were taken up by someone who was presented with a mental health problem and admitted primarily for that reason. But when we looked at this survey, which looked at just under half of all paediatric units in England last year to ask them for their perceptions of what happened, over 90% reported an increased number of admissions, and some of them said they were making up a majority of the cases on their wards, which was unusual, which has really, as I say, created all these problems about how we manage restraint, how people are artificially fed with nasogastric tubes and eating disorders, a whole load of skill sets, legal frameworks, and problems and quality of care that have massively faced children and the people looking after them. And that's just a highlight. Another thing, perhaps we could come and talk back at another time, is that I'm just leading a study called the Mental Health Admissions to Paediatric Ward Study. This is a cross England study that's funded by the NIHR, where we're actually doing a mixed method study to really understand the health needs of children who are admitted to that ward. The reality is the prevalence of mental health, the number of attendances still to emergency departments, and the lack of evidence and service provision to keep children in crisis out of hospital means that this is going to be an ongoing problem for a long time, and it is going to mean reconfiguration of paediatrics probably, and it is going to mean skill set changes for those who look after children. But that's a project that we just started in June, where we're actually working with children's units around the country with NHS England, the Royal Colleges, the Nuffield Trust, a whole host of the Royal College of Nursing, and a really lovely stakeholder group of children and young people, people with lived experience and staff with lived experience of this, to design a theory of change about how we might make that better, but embedded in that some mixed methods research, which is some qualitative work and some qualitative and quantitative work in that. Someone talked about hypotheses earlier. I think, as we said in the break in the middle with the questions, I don't think we really know, and we may not ever know, why it is that we've seen such a surge in mental health problems, and particularly at the acute end, we're seeing, as a metric, we're just seeing a service that has been drowning with new presentations of people with severe end mental health presentations, and why that might be. Well, and we've talked about them a little bit already. We know there's evidence that isolation is associated with depression. We know that people had reduced access to healthcare at points and had their healthcare disrupted, which can impact on their outcomes and potentially make presentations and mental health conditions that were pre-existing worse. There's also the impact on families, and people often don't talk about this, but it's estimated that 10,000 young people lost at least one caregiver during the first year of the pandemic. And disproportionately, as we know, that COVID tended to unfortunately be more lethal for people who are older, and we know that generally where lots of the more needy children who are under social care and are actually looked after by extended members of family, so where grandparents look after children because there've been social problems with their actual biological parents, they were going to be disproportionately hit in this way as well. And we know the economic pressures, we know the deprivation interaction that we've talked about. So a whole host of hypotheses that are being tested that seem plausible, but people are still picking out. And I'm just going to finish on education, because this is close to my heart. And we talked about education a little bit in the question session, because, you know, education is such a critical part of why all of us are in this room now, and have got to where we have. And, you know, data from this year shows how disproportionately different areas of the world have been affected by school closures, because school closures happen all across the world. And globally, from February to January this year, it was estimated that kids are 8.2 months of education behind. And in richer countries, that's less. And of course, ironically, we all know that richer countries will be able to catch up more quickly. We hope, or we should be able to. But some of those countries in the developing world and low-income countries are going to find this a real problem. And lack of education and lack of reading skills are really critical to the global political climate, because in a world where information is thrown at you left, right and centre, being able to critically appraise and being educated to do that is profound, as we all know. And it's really the developing world, I think, where the major problems are. And just to finish on that, you know, pre-pandemic, about 60% of 10-year-olds couldn't read a simple text in middle and low-income countries. In March 2022, it's estimated that's risen to 70%. And in Latin America, that's 80%. And there's an estimated impact on the global GDP of $21 trillion impact of that loss of education in children. It's astounding. So that's where I'm going to finish. And I know that we said we would come up with some solutions, and I think we mentioned that before. I mean, I think one of the solutions is people just need to get real a bit, and there's lots of arguments about we should have done that, we should have done this, and that is important. But for those of us who are researchers and clinicians who work with children and young people and educators, whatever, or those of us who have children, and that's my daughter as she wanders off into the future, so I've got a personal concern about what happens to children. I don't know who the boy is, she's not marrying him. But, you know, as children move into the future, what do we do about it? But I think we need to move on and start thinking about mitigations and less recriminations to some extent for children. You know, schools were closed down. That was bad for them. It is something we need to think about for next time, but if there's a pandemic. But ultimately, how do we make things better for children and young people? I think making that, as people are interested in child and adolescent health, making a racket about the trajectories, that first slide I showed you, because, you know, politicians and people who and policymakers, adults always take up a bigger chunk of the pie, but children become adults. And if we don't get this right for this generation in terms of their mental health, the deprivation differences and how the pandemic has affected children and young people, and particularly education, that's a global problem. We are potentially up for a hell of a load of trouble at a very individual level, but at population level that will affect us all. Thank you for your attention. I think I've gone a bit over.
Thank you very much, Lee. That's okay. We have 4 minutes for a question. And during your talk, your very interesting talk, thanks so much. We had a bit of debate around policy and how to bridge, I guess, the gap between theory and practice. And so I'm going to synthesize a few questions that I got around that subject. If you could comment on, I guess, what is the one piece of knowledge that we now have, given the experience we've had in informing and working with the government to inform change and improve children and adolescent mental health. What would be your recommendation for the future?
Okay, I'm going to say 2 things. One, what I've already said, which basically, you know, wake up everyone. We really have got to invest in this group that have been hit. They were already, mental health wasn't great before the pandemic, but it's been knocked for 6. And so it needs a whole round approach, but it needs to be made a government priority. And I don't, you know, and policymakers, not just in the UK, across the world. And I'm not sure I've necessarily heard that loud enough about what we need to do. And the second thing is, I think we need to have a good think next time. And there is a COVID inquiry, but we do need to think again about how and don't want to get into the debate about the role that children had in spread and that sort of thing, but and schools and safety in schools and all that. But I think, you know, I'm going to land myself down to say that I don't think we thought about children first. We closed schools because we thought children might be a major point of spread, and we thought children might get unwell, very unwell with COVID. So that was all reasonable. But I think we did have a point at one point where pubs were open and schools were still closed. So I don't think children were always on the front of what people were thinking about in terms of policy. And if this happens again, then we need to have children front and center on the basis of what we've experienced with the last pandemic, really. But every pandemic,
yeah, that's good food for thought and advice. Thank you very much again to the speakers and Pravita, and to those who have questions. So thanks everyone for contributing to this event. I just have an announcement. Our next Catalyst seminar will be on the 16th of November, also at 1 to 2:15 p.m. And the topic will be autism, neurodiversity, and mental health. And we'll have Professor Will Mendy and Dr. Jan Wollstonecroft speaking at the event. So we will soon circulate further information, so please make sure to visit the website of the Children and Young People's Mental Health Research at UCL to sign up to our newsletter if you haven't already, to stay tuned. And we will be sending out the recording of the event, which should include the transcripts as well. So thanks everyone for your time and attention.
Thank you.
Bye.